So, yes, I will be talking about this journal article that I read. This doctor in Canada, he did a very extensive literature review discussing and investigating long-term visual outcomes in prematurely born children. So I'm just going to get into it. Okay. All right, so this is my agenda. Sorry, I'm getting the hang of the keys here. So this is my agenda. I'm going to introduce the topic and define some terms just because I'm trying to be mindful of my audience today and just kind of the general ophthalmology knowledge. I know for me personally, we don't get a lot of it in med school. So even my understanding of ophthalmology pathologies is still a little limited. So I'm walking with everyone in this and trying to keep things simplified as possible. And the goal of this presentation is not to really learn ophthalmology pathologies, but more to highlight trends in prematurely born infants and the kinds of things that they have to deal with when they're with their vision when they're born premature. So I'm going to talk about retinopathy of prematurity, which is a huge thing in pediatric ophthalmology. Then I'm also going to talk about cerebral visual impairment. Then I'm going to move on to visual acuity and refractive income outcomes and how that looks in premature infants. And then I'm going to talk about visual fields, contrast sensitivity, and then strabismus and binocularity. And then I'm going to wrap things up with just kind of the high level points and just my thoughts on moving forward after reading through something like this. So again, I will do my best to simplify concepts and reinforce definitions so that we can all, for the most part, understand what's happening when I talk about this literature review. So this was the article that I read and reviewed. So as a physician in Canada, he was giving a big lecture, and he was the one responsible for doing this review of looking through various research papers and articles to kind of culminate into this article, just some observations he made about infants that were born prematurely and with certain pathologies. So I'm going to get into some basic definitions. So a premature infant is really any infant born before the 37th week of gestation. And there's a wide variety of factors that can influence prematurity. It could have something to do with how the infant is sitting in the womb, how the placenta is sitting in the womb. Maybe the infant is not alone. Maybe it's a twin or triplet. Mother's health can have some impacts on prematurity. Did she have any prior miscarriages? Does she have an infection? There's just so many things that can influence prematurity, which is why you get a wide variety of symptoms. And also that 37th mark is a huge point in the timeline. So a premature infant at 28 could look different from a premature infant at 36 and 5 days, for example. So you get a wide variety of presentations when it comes to premature infants. So with pediatric ophthalmologists specifically, when a baby is born premature, the big thing that they're worried about is something called retinopathy of prematurity. So this is essentially a disruption of the blood vessels in the retina or the back area of the eye. So a lot of times when a baby is born too early, their blood vessels in the back of the eye didn't have time to quite fully develop, but now they're out in the world. And so the blood vessels start forming abnormally. So that's a big one for premature infants. There are other things we're worried about when a baby is born prematurely. Cerebral visual impairment is one. So are there any damages to the brain and the neuronal pathways that are involved with vision? And this is a big theme you'll see in ophthalmology or just anything with eyes. It's not enough to have good anatomically sound eyeballs. You need to have good brain connections too for your vision and your development of vision to be good too. And it's also, there's that theme of eye health and vision health. And that falls in line with that theme of the anatomy and then the pathways for vision. Visual acuity is also, okay, so visual acuity is what you do. Sorry, let me define these terms better. So visual acuity is your ability to make out shapes at certain distances. So in layman's terms, this is your short-sighted versus far-sighted. So that's how I would define visual acuity. Visual field is what you can see when you are staring straight ahead at somebody and not moving your head, not moving your eyes. What can you see in your periphery? And then contrast sensitivity is your ability to make out patterns and shading and distinct lines on small objects. So those are some important definitions I think that'll be helpful as we move forward through this discussion. So this is just a very easy schematic of retinopathy of prematurity. So like I said, it's abnormal blood vessel growth in the vitreous of the eyeball. So that's the jelly part of the eyeball that makes up a bulk of your eyeball. And that's not good for vision and eye health. Risk factors for retinopathy of prematurity include prematurity, obviously, anemia, oxygen, blood transfusion, difficulty breathing, respiratory distress, and low birth weight. The oxygen one is very interesting because a lot of times if a baby is born preterm, they need oxygen because a big thing about preterm infants is their lungs haven't developed quite as well. And so a lot of times preterm infants, when they're born, they spend some time in the NICU and they spend some time with some oxygen. But if you have too much oxygen, that can actually exacerbate, interestingly enough, exacerbate retinopathy of prematurity. So when treating with oxygen, and when we have a high suspicion that an infant might have retinopathy of prematurity, we have to be mindful about that oxygen use. So if a pediatric ophthalmologist has a suspicion for retinopathy of prematurity or ROP, these are the criteria that they use to determine how severe that retinopathy is. They use the retinal vascular tortuosity, so the tortuosity of those blood vessels, those abnormal blood vessels, and they look at the vascular caliber of those blood vessels. And then they also look at how close these abnormal blood vessels are to the optic nerve. And that's what they use to classify how severe this pathology is in the baby. And being able to define how severe it is very helpful in determining treatment and helping to reduce vision loss overall. Because a lot of times the cases are going to be benign. The cases a lot of times can resolve without treatment, but if the cases are so severe, they can be treated with laser. So they'll just get a laser in there and obliterate those abnormal blood vessels, or they will use anti-VEGF injections. So VEGF promotes blood vessel development. So if you get the anti version of that, you are inhibiting those abnormal blood vessels. And anti-VEGF is actually a treatment that we use in something called wet macular degeneration. It's an eye disease we see in older people, but it's called wet because this is also a disease process where they're developing abnormal blood vessels in the back of the retina. So the same concept applies here. So that's kind of just like a quick little overview of retinopathy of prematurity. So now I'm going to discuss some of the articles that were mentioned in this literature review. So the author looked at infants in Canada. He looked at a study in Canada, and according to one study he looked at, about 40% of infants at risk for ROP that developed ROP, 5% needed treatment. And then he looked at a study in the USA that said that 66% of infants at risk for ROP developed ROP and 9% needed treatment. So this further emphasizes what I said earlier, that most cases of ROP can resolve on their own. Some of them need treatment. But what the author noticed that was interesting was that there was a wide variety of rates between all of the different studies he looked worldwide. So some, and even between Canada and USA, we see a little bit of a difference in terms of the rates that they studied and the percentages they studied and proportion they studied that they determined that needed treatment out of the ROP cases. Regardless, though, there was a correlation between increased risk for ROP in preterm infants. No matter the rate, the trend was the same. If the baby was preterm, they had an increased risk of developing retinopathy of prematurity in every regard. So that's retinopathy of prematurity. Next, I'm going to move into cerebral visual impairment. So this gets more into that theme of vision impairment because there's something wrong more in the brain, in the processing centers of our vision. So causes of cerebral visual impairment include things like interventricular hemorrhages, periventricular leukomalacia, hypoxic ischemic encephalopathy, and hydrocephalus, to name a few. So again, these are all things that cause damage to the brain. And just expanding on that idea a little bit more. So our central nervous system as it's developing and its circulation is extremely susceptible to damage in areas that are key for vision. So for example, the watershed zones, if there's damage to that, you're going to see defects in the cortical spinal tracts and optic radiations. In the case of intraventricular hemorrhages, when you see that bleeding, you can see the enlargement of ventricles and the seepage of that hemorrhage into brain tissue, thus damaging tissues necessary for vision processing. You can have isolated kind of lesions of cerebral visual impairment, and the paper defined this as lesions that were posterior to the optic chiasm. You can also have combined cerebral visual impairment, so posterior and anterior. So this would be a lesion posterior to the optic chiasm in addition to optic nerve injury or optic nerve hypoplasia or increased optic nerve cup to disc ratio. And this is where history is really important. And I mean, this is a theme you see in a lot of neurology just in general. If you take a good history and you're able to notice patterns, what side is the defect? Oh, how are they describing their defect? You're able to kind of really focus in on where the lesion or where the problem is. Same with the vision. You know, you can, not to get into the weeds too much, but the article talked about like if the patient is able to talk about shapes or, you know, colors, certain things about how they describe what they are seeing can help give you clues as to where the lesions are, where the problems are. So some symptoms of cerebral visual impairment, it's a wide spectrum. Strabismus, mild learning disabilities, variable visual acuity, variable visual field defects, nystagmus, photophobia, poor fixation. Again, it's a wide spectrum, and I'm trying to keep it very simple, but it's a wide spectrum because it depends on where the lesion is. It depends on how many lesions you have. It depends on how severe the lesion is. And so that's why you get this wide variety of presentations when there's damage to that processing center in the brain. So a study that was looked at in this literature review was the ETROP study. So in this study, there was a cohort of 6-year-olds who had blindness. And so this gets back again, I'm going to repeat this through this whole thing, the theme of anatomy versus the processing part of vision and eye health, right? So in this cohort of 6-year-olds who had blindness, they had great anatomy. They had undergone that laser treatment that I mentioned earlier to get rid of abnormal blood vessels so that their eyes looked great. But cerebral visual impairment, lesions in that processing center was the main culprit for their vision loss. So it didn't matter that we were able to fix the anatomy of their eye. Something happening in their brain or in their brain development is what was responsible for them essentially not being able to see. So next, I'm going to talk about visual acuity and refractive outcomes and how prematurity has an impact on those things. So like I mentioned in the other slide, this author, again, noticed that the success of laser treatment in improving the anatomy of the eye didn't really help improve visual acuity. So again, visual acuity is our ability to see certain shapes and things at given distances. So like I said, this is like your nearsightedness versus your farsightedness and your astigmatisms. The author did note that there was not enough data to compare visual acuity in laser versus anti-VEGF injection outcomes. So he's saying that even though we gave them treatment, we can't determine it, we couldn't really fix visual acuity. And on top of that, we were not able to determine which of the treatments were better. Was laser better? Was the anti-VEGF injection better? The author assumes that maybe if we try both, we can fix visual acuity, but there's not enough data to really support that. And then interesting to note is that preterm babies who did not have retinopathy of prematurity still had risk for visual acuity issues. So a study the author looked at was a group of adults who were born between 22 to 25 weeks gestation, and it showed that they had more risk and more problems with visual acuity than the control group of adults. And just overall, refractive errors are the most common ophthalmology problem in the world. I mean, everyone, we know so many people with refractive, errors and visual acuity issues, but especially in prematurity, it's huge. So myopias, astigmatism, what have you. So just kind of little crash course on visual acuity and refractive outcomes. Myopia is where the diameter of your eye is too long. And so when the light comes in to focus the images on the back of your retina, it focuses in front of your eye, which is why you're short-sighted. Versus hyperopia, the diameter of your eye is too short. And so the images focuses behind the eye. And that's why you're able to really only be able to see farsightedness. And then I have that schematic of astigmatism, but I felt like the best way to describe astigmatism is with the picture on the right. I mean, if somebody has an astigmatism, that's essentially what they see. Lights just look like lines, and the lights are being refracted and just really not being able to focus. So next, the article talked about visual fields. And again, visual fields are when I am standing still, my head is still, my eyes are still, and it's what I'm able to see in my periphery. And interestingly enough, in this literature review, the author determined, after all the things that he researched and investigated, he determined that he felt like there wasn't enough evidence to support that there were major influences of prematurity on visual fields. He looked at a study comparing patients who had retinopathy of prematurity that resolved with no problems, and compared that to patients who had severe retinopathy of prematurity and required treatment. And in both cases, there was not enough significant difference in terms of their visual fields. And then contrast sensitivity was another thing that the author didn't find much significance in terms of its influence from prematurity. So again, contrast sensitivity is a person's ability to be able to see shading and patterns and fine details of small things very clearly. And the author just didn't feel like there was enough support or enough evidence to prove that there was significant influence of prematurity on contrast sensitivity capabilities. Um, it is unknown if being treated with the anti-VEGF has any impact on contrast sensitivity, and that could be a question for further investigation. And the next thing he looked at was strabismus and binocularity. And so based on the things he looked at, he gathered that 5 to 14%. Okay, so there was a 5 to 14% presence of strabismus in premature infants, whether they had ROP or not. This was another situation where the parameters varied a lot between all the studies he looked at, and that's why that range is so big. And when I saw that, it was very frustrating that it was a 5 to 14% range. But again, all the studies had their own little parameters. But again, this was the thing where despite the variances in their parameters, the trends were the same. If you had a premature infant, their risk for strabismus was higher. And if you had just a premature infant, their chances for strabismus is higher. But if you have a premature infant who also developed ROP or also developed some kind of neurodysfunction in their processing pathway, then their risk for strabismus goes even higher. And this is another case where the author felt like we needed more data to study the effects of treatment on premature infants and how it could affect strabismus and binocularity. These are some risk factors. A lot of these things are just common things that normal OB-GYNs and family med doctors are looking at when a baby is born preterm. So a lot of this is pretty, makes a lot of sense and is very interrelated. So you have poor fetal growth, lower gestational age, poor lung development, cerebral palsy, cognitive disability, and a lot of other things I've already mentioned earlier in this presentation. So in conclusion, I realized that was like a lot, but in conclusion, the visual system is particularly vulnerable to damage in those who are born premature. And the thing to note is it does not matter if the baby has developed retinopathy of prematurity. Just being premature puts that baby at risk for short-term and long-term vision complications. And so that's why it's very imperative to recognize risk factors early and keep this in mind. And when a baby is born premature, a pediatric ophthalmologist antenna is going to go up for retinopathy of prematurity. But thinking about these other things, because retinopathy of prematurity is not the only thing that can dictate poor vision outcomes. Simply being premature can have some effects. And then I just had some considerations after reading this literature review and just kind of the future of eye health and vision health in children. So there's actually a trend right now. We're seeing decreasing pediatric ophthalmologists. And I think the most recent thing I read said that there are some states where there's only 2 practicing. It's very severe. There's a lot of them retiring, and we are not seeing a lot of them, we're not seeing a lot of ophthalmology residents pursue pediatric fellowship. And that's the only pathway to pediatric ophthalmology. So there's a lot of access issues. Being in the Kansas City metro, we're very fortunate to have the Mecca of children's care, Children's Mercy. They have a very strong pediatric ophthalmology department, but that can't be said for a lot of places in the country, especially rural places. So that's a concern. And so if we have poor access issues, maybe it's a thing that we empower our OB-GYNs, our family med docs, and maybe they're already doing this, but just really empower them to keep their antennas up about eye problems in premature infants. And then we also just need to, I mean, this is nothing new, but bolstering prenatal care and healthcare access for new mothers or patients planning to become mothers. Just ensuring healthy delivery. It starts from conception all the way to delivery. So just ensuring that, new parents have all the information, they have access to their healthcare checkups, they have support, and it's a lot. There's a lot of variables and moving parts to that entire process. And I mean, I'm seeing it firsthand on my OB-GYN rotation, but I mean, it needs to be done so that we can ensure that more babies are not being born premature, because prematurity comes with a lot of risks and a lot of, developmental issues. And there's also an increasing myopia public health crisis. So I just think about the children and the babies born prematurely who already might have some developmental issues with their eye health and their vision health, and they're entering into a world where we have a huge myopia problem. We don't go outside anymore. We're sitting in front of our screens, and that already is so bad for our eyes. And I mean, there's a lot of other variables contributing to our myopia problem, but myopia right now, so nearsightedness, which is myopia, is currently a public health crisis. And, maybe we can burn the candle at 2 ends, so to speak. So take care of the baby while they're growing in utero, but also let's maybe work on minimizing myopia outside. So if these children are born preterm, their conditions probably aren't worsened by the society we've developed, where we really like to, a society that kind of encourages myopia possibly at the current moment. And then just kind of a final note on quality of life in children. There are enough studies to show that when a child can't see, that's huge for them. I mean, it's huge for all of us. I mean, my personal take, but if someone walked up to me and said, okay, out of all of your 5 senses, you can only pick one and you have to give up the rest, I would always pick my eyesight, because at least I can see what's going on. If I can't hear, I can't smell, I can't taste. And that's my personal take, but vision is so huge and so instrumental in our perception of the world. None of us like when our vision changed, but especially in children, there are some studies out there that have looked at quality of life and how children rank their quality of life when their vision is not great. So let's try and minimize poor vision in children. Let's take care of babies. Let's try to minimize premature babies. And if a baby is born premature, let's keep our antennas up on their eyesight, their vision. And I think that would be I mean, it's a tall ask, obviously, but just some things to consider moving forward so that we can ensure the eye health and the vision health of babies and children moving forward. So yeah, that's just kind of my thoughts on this whole thing. And that's really all I have to present today. It's a topic I'm very passionate about. But I thank you all for listening to this. And yeah, I'm done.